Okay, today we'll be covering Chapter 16, going over various components of childbirth. Part of our competencies that we need to acquire per the National EMS Education Standard, considering special patient populations. This recognizes and manages life threats based on simple assessment findings for a patient with special needs while awaiting for additional EMS response. We'll be covering obstetrics, recognition, and management of various illnesses and illnesses related, normal child delivery or childbirth, vaginal bleeding in a pregnant patient, also neonatal care, care for a newborn patient, and neonatal resuscitation. This will be in addition to what we learned in our BLS life support component. Also looking at gynecology, recognition and management of shock associated with vaginal bleeding, trauma. This uses simple knowledge and to recognize and manage life threats based on assessment findings of acutely injured patient while awaiting for additional emergency personnel to respond. And then special considerations in trauma, recognition of and management of a pregnant patient, a pediatric patient, and geriatric patients. So childbirth is a normal and natural part of life. Your part of the process involves helping, guiding, and supporting a newborn as it is born. It's really not that difficult to perform a normal delivery. Usually it's the mother does all the work and we're just there to be of moral support. After birth, you should ensure that the newborn is breathing adequately and then keep them warm. And always remember that after delivery, you now have two patients. You have the newborn as well as the mother. Two indicators of impending birth is very frequent contractions and crowning. During the first stage of labor, the pregnant woman's body is preparing for delivery. This is characterized by the occurrence of contractions. The bag of waters breaks. There's often a bloody show or the mucus plug comes out. The newborn's head does not appear during contractions. If the woman feels like there is pressure near the vagina or in the vagina and tells you that she feels like the baby is coming, make sure it's okay and with her and check the vaginal area to see if there is crowning or not, and then report your findings to the responding ambulance crew. During the second stage involves birth of the newborn. You will see the newborn's head crowning during contractions, and at which time you must prepare to assist with delivery. If you are on a transporting unit, this is the time when that ambulance should pull over to the side of the road and the driver should get in the back with you or the attending crew. We don't deliver babies on the move, and that is extremely risky and dangerous for the crew, the baby, the mother, and everyone else involved. It's at this time that you have run out of time to transport. During the third stage of delivery, the third stage involves delivery of the placenta or the afterbirth, and you must assist in stabilizing the condition of the mother and the newborn during the delivery of the placenta. In most normal deliveries, one question that you need to be asking yourself, is there time to reach the hospital? Do we stay here and deliver the baby, or do we have time to transport? We're not going to run lights and sirens with a pending delivery, except for a very small number of circumstances. One question is this a woman's first pregnancy? This will help you determine how much time you have. Generally speaking, a woman experiencing her first labor usually has more time, and the progression is a little bit slower of that delivery. Has the woman experienced a bloody show? If yes, the first stage of labor is about to begin. So depending on the situation, you may want to go ahead and prepare for delivery at that point. Has the bag of waters broken? The bag of waters usually breaks towards the end of the first stage of labor and may give you some idea of the progress of the birth. Another question is, how frequent are the contractions? If contractions are more than 5 minutes apart, you can usually transport the woman to the hospital. This is a good indicator that you still have some time. Contractions less than 2 minutes apart usually indicates that delivery will occur very soon or is pretty much imminent. Does the woman have the urge to have a bowel movement? When a newborn's head is in the birth canal, it presses against the rectum, and the woman may feel the urge to have a bowel movement. Do not allow her to go to the toilet. This urge is an indication of imminent birth. And then is the newborn's head crowning. Crowning indicates that the newborn will be born in the next few minutes, and at this point, transport is no longer on the table as an option. Is the transport available? Is the ambulance responding? How far is it to the hospital? Will bad weather or natural disaster or traffic prompt arrival or prevent prompt arrival of that transport unit? A lot of times in blizzards and severe storms, things like that, weather conditions prevent us from actually being able to make decent progress to the hospital. So timing your contractions or the mother's contractions, time the contraction cycles from the beginning of one contraction to the beginning of the next, from start to start. If the contractions are less than 3 minutes apart, delivery is close. As mentioned in a previous slide, if they're 2 minutes apart, your delivery is pretty much imminent. If you're about 5 minutes or a little bit longer, you still have some time to buy and play with, and you may be able to transport to the hospital without being presented with delivery. Of course, with all instances of emergency medicine, these are all just indicators, and every situation is different, so be prepared for things not to go as planned. So detecting crowning, this is observed from the vaginal opening during a contraction. If you see the head crowning during contraction, prepare for delivery, and do not risk transporting the woman to the hospital if the child's head is crowning. As you are preparing for delivery, keep calm. Everybody needs to remain calm. Keep the woman calm. Keep yourself calm. Remember, you are responding to the emergency, therefore the emergency is no longer happening. Emergency is over when emergency responders arrive. Childbirth is a natural process and typically goes very smoothly unless there are pre-known conditions or things like a breached birth or limb presentation are present. Otherwise, typically these would be conditions known in advance that could occur. And typically measures have already been taken to manage that. In most of these cases, the mother would already be in the hospital being watched by hospital staff, but things don't always go as planned. So keep that in mind and be prepared for that as well. But remain calm. Realize that you will not be able to maintain a sterile environment. Try to stay as clean as possible, hand washing. If your first responder kit has an OB kit or an obstetric kit, use that. If not, standard PPE. Make sure you have plenty of clean towels. Towels work better for the absorption and also warmth. But if they're lacking in numbers, you can use sheets as well. Place the patient on a firm surface laying on her back with some padding. Elevate her hips 2 to 4 inches off the ground. Have her on her back with her knees bent and feet flat on a surface beneath her and her legs apart. A woman in childbirth will expel both blood and body fluids. So use sterile gloves whenever possible, or your standard PPE, regular gloves. Wear face and eye protection. Wearing a surgical gown can help keep fluids off of your body, but that's not a necessity. If you have no option, you can use a sheet, drape that sheet over you kind of like an apron as well. Some of the equipment that we'll be looking at, or that you'll be using, in an OB kit, you'll have sterile gloves, umbilical cord clamp, sterile drapes and towels, sanitary pads. There will be 4x4 gauze, towel or blanket for the newborn, a bulb syringe for suctioning the airway, and then a plastic bag to put this placenta in after it's been delivered. In addition, you'll need some sheets and towels for mom, some extra sheets and towels for baby, suction if available, oxygen, and then a newborn-sized face mask. This is in the event that when they are first delivered, after initial stimulation and suction, they still aren't breathing, and you have to start giving them resuscitation. These are all typically contained in an OB delivery kit. If you do not have that kit, you can go ahead and assemble these things in advance, or know of these things that you need to look for once you're on scene. Remember, your primary assistant or purpose here is to assist with the delivery, and be prepared for the fact that you're about to have 2 patients. Do not neglect to perform a patient assessment on the pregnant woman. Ideally, if you can get these before delivery, your sample history and other things like that, determine if there are any pre-known conditions, any medical conditions, things like eclampsia, breech birth, things like that. Obtain your first set or your baseline set of vitals, and then repeat them at least every 15 minutes. If the patient becomes unresponsive or semi-responsive, or they become hypotensive, you're going to want to reassess your vitals more frequently. Throughout the delivery process, continue to monitor her ABCs. Your primary purpose is to assist in delivery of the newborn. Do not let the woman go to the bathroom, and do not hold her legs together. You're not going to stop the delivery. Holding legs together can damage and pose a risk to both mother and infant or newborn. Be as clean as possible during the entire delivery process. Do not touch the vaginal area except during delivery. So during the progression of delivery, the newborn's head should emerge slowly to prevent undue stress on the newborn and tearing of the vaginal tissue. As the head emerges, support the newborn's head and tell the woman to stop pushing. Do not attempt to pull during the delivery. In a normal birth, the newborn will turn to its side by itself after the head emerges, and the rest of the body will deliver spontaneously. The newborn will be wet and slippery. If you drop the baby, pick them up, it's okay. Dry them off. Keep the newborn's head at about the level of the woman's vagina. If the amniotic sac has not broken, tear it with your fingers and push it away from the newborn's head and mouth. If the umbilical cord is wrapped around the newborn's neck, attempt to slip the cord over the newborn's head. If you cannot disentangle the newborn from the umbilical cord, attempt to reduce pressure on the cord. Never pull on the umbilical cord, as they are extremely fragile. And then clear the newborn's mouth and nose using your bulb syringe that is typically supplied in the OB kit. If you do not have one of those, you can simply use a gauze to wipe the mucus away from the newborn's mouth. But if you do have the bulb, suction the mouth first. Always depress the bulb before entering the oral airway, and then the nostrils afterwards. Do this 2 to 3 times until they are clear. And then place the newborn on the patient or the mother's abdomen to keep the newborn from losing too much body heat. So if the newborn is not breathing, go ahead and suction their mouth and their nose again. Rub the baby's back. Flick the bottom of their feet or the soles of their feet to stimulate breathing. Sometimes this kind of stimulation is enough to make the baby's body realize, like, oh, I have to breathe, or remember to breathe. After all, this is the first time that they ever have breathed. So sometimes they need that a little bit of stimulation. We don't need to panic over that initially. Use a towel to dry the newborn, and then wrap the newborn in a blanket to keep him or her warm. Place the newborn on their side with their head slightly lower than the trunk to aid drainage of secretions from the airway. When the umbilical cord stops pulsating, clamp it with the clamps that are supplied in the OB kit, or tie them with gauze between the mother and the newborn. You want to leave 6 to 8 inches initially of that umbilical cord for the newborn. A lot of times, if there are complications or delivery complications, having that umbilical cord to be used as a venous access for the hospital is very beneficial for them to have there. Note the time that the delivery occurred so it can be properly recorded on the baby's birth certificate. And then in the rare event that you encounter multiple births, prepare for a second delivery. Keep in mind that if the mother has not received proper prenatal care, she may not know if she has twins or triplets or so on. And there have been surprises in the past as well. So always be prepared for a second baby. But either way, you still have the placenta that you have to deliver as well. So be prepared for that. The diagram here is just an example of kind of flicking the soles of the infant's feet. Sometimes you can use your fingernail and just kind of scrape them, the bottom of the feet a little bit too. Any kind of gentle stimulation like that is enough to help stimulate the breathing of the newborn. Okay, so delivery of the placenta. It is usually delivered on its own within 30 minutes after delivery. Never pull on the umbilical cord to help delivery of the placenta. Let it take its time. It'll come out on its own. Leave the umbilical cord uncut and attached to the placenta and the newborn until the transporting EMS unit arrives. After the placenta is delivered, wrap it in a towel or a newspaper with 3/4 of the umbilical cord and place it in a plastic bag and transport to the hospital. Typically OB kits or obstetrical kits have this plastic bag specifically for the placenta supplied in them. Keep it at the same level as the newborn to prevent blood from the newborn flowing back into the placenta. This would be essentially blood loss or an enclosed hemorrhage of the newborn. And the mother's bleeding usually stops after the placenta is delivered. If it does not, massage the uterus to help stop the bleeding, and by placing one hand with fingers fully extended just above the mother's pubic bone. Use the other hand to press down into the abdomen and use a circular motion gently massaging the uterus until it becomes firm. This usually takes about 3 to 5 minutes. Sometimes a little bit longer, sometimes a little bit quicker. Not every mother who has delivered a baby will require this either. Continue to observe the mother and the newborn carefully and keep them both warm. Cover the newborn's head. This is where we lose the majority of our body heat is lost through our heads. Approximately every 3 to 5 minutes, check the uterus for firmness. Recheck the vagina for any excessive bleeding. Remember, all these towels and blankets that we have the mother wrapped in, they can hold a lot of fluid and a lot of blood, and it could go easily missed if the mother continues to bleed. It is normal for a mother to lose about 300 to 500 milliliters, 1 to 2 cups of blood during delivery or during the whole process. Continue to massage the uterus using that circular motion if it is not firm or if bleeding continues. Clean the mother with clean, moist towelettes or clothes, and give her small amounts of water to drink if she is thirsty. Don't let her take large gulps or chug a glass of water, just small sips. The vast majority of newborns breathe spontaneously within 30 to 60 seconds after birth. Sometimes after drying and tactile stimulation, newborns who do not breathe within the first 60 seconds after birth or are persistently bradycardia with a heart rate less than 100 beats per minute, despite appropriate initial actions including that tactile stimulation, may receive positive pressure ventilation at a rate of 40 to 60 breaths per minute. The progression from primary apnea to secondary apnea in newborns results in cessation of respiratory effort or activity before the onset of cardiac failure. This cycle of events differs from that of asphyxiated adults who experience concurrent respiratory and cardiac arrest or failure. For this reason, neonatal resuscitation should begin with ventilation. rather than with chest compressions. Delays in initiating ventilatory support in a newly born infant increases the risk of death. Chest compressions are a rare event in full-term newborns, approximately a tenth of a percent, but are provided more frequently to preterm newborns. When providing chest compressions to a newborn, it may be reasonable to deliver 3 compressions before or after each inflation, providing 30 inflations and 90 compressions per minute. That's a 3-to-1 ratio for a total of about 120 events per minute. Ectopic pregnancy and shock in pregnant women. An ectopic pregnancy occurs when a fertilized egg becomes implanted in the fallopian tube rather than the uterus. As the embryo grows, it expands and causes the fallopian tube to rupture, and this rupture causes acute abdominal pain, internal bleeding, and shock. Treat the patient for shock and arrange for prompt transport. This is a traumatic type injury, and that hypotensive crisis or hypotension often occurs with these types of ruptures. Miscarriage and vaginal bleeding. A miscarriage or spontaneous abortion, as is commonly referred to, is delivery of an incomplete or underdeveloped fetus. If a miscarriage occurs, save the fetus and all tissues that pass from the vagina, control the woman's bleeding and treat her for shock, and arrange for prompt transport. Vaginal bleeding in a pregnant woman is often the first sign of miscarriage. Anytime a woman experiences vaginal bleeding, perform a patient assessment, obtain a good medical history. Remember to use your sample acronym. Obtain a good set of vitals and determine whether she is experiencing shock, and arrange for that prompt transport. Of course, always relay your findings to the responding EMS unit if you're able to. A woman who miscarries will be upset about losing her newborn and will need emotional support as well as emergency medical care. Any newborn weighing less than 5 pounds or 2 kilograms or being delivered prior to 36 weeks gestation is considered to be premature. Premature newborns are smaller, thinner, and are typically more redder than a full-term newborn. Be sure to keep them warm as they lose body heat more rapidly and lack the ability to produce their own. And then arrange for prompt transport. Taking a second look at the bag of waters. In rare circumstances, the bag of amniotic fluid does not break. Carefully break the bag and push it away from the newborn's nose and mouth so that he or she can breathe. Be careful not to injure the newborn in this process, and be prepared to suction the newborn's mouth and then nose to help him or her begin to breathe. Remember, sometimes stimulation is necessary during this process as well. So the following 3 conditions or situations will result in or can result in rapid transport to the hospital or the need of rapid transport to the hospital. The first one is a prolapsed umbilical cord. On rare occasions, the umbilical cord appears from the vagina before the fetus is delivered. The cord may become compressed between the newborn and the woman's pelvis during contractions, cutting off blood supply to the newborn. Prolapse of umbilical cord is a serious emergency that requires immediate transport. Place the pregnant patient in a position that raises her hips and keep the exposed portion of the cord covered and moist, and do not try to push it back into the vagina. Administer oxygen to the pregnant patient. If it is available, arrange for that rapid transport. And some EMS systems recommend placing the woman in a kneeling position, and this alleviates pressure from the cord. And you would want to check with your local protocols before performing that or having a pregnant woman get in that position. Next, we have breached deliveries. This is where the newborn's buttocks come down through the birth canal first. You want to go ahead and, once you recognize this or realize this is what's going to happen, is arrange for that prompt transport. A breech birth does slow labor, so there is more time for transport to the emergency department. Of course, once delivery begins, we want to stop that transport, attempt the delivery. You'll want to support the newborn's buttocks and legs as they are delivered, and the head usually follows on its own. But if the head does not deliver within 3 minutes, go ahead and transport or arrange for that prompt transport. The primary attendant or the person assisting with the delivery will need to insert a gloved hand into the vagina and use their fingers to keep the newborn's airway open by forming a pocket over the newborn's nose and mouth. In very rare cases, you will see a limb presentation. This is where an arm or the leg is the first part of the newborn to appear in the birth canal. Limb presentation is an extreme emergency that cannot be handled in the field, and they have to be rapidly transported to the hospital. The earliest notification to the receiving hospital, the better, so that they can be prepared for your arrival when you get there. So stillborn deliveries, sometimes the newborn dies in uterus and before labor. Oftentimes the pregnant woman will know this or have a feeling that this has occurred. Not everyone receives the proper prenatal care that they should, but there's usually that sense. They won't feel the activity of the fetus for several days or however long it has occurred, the elapsed time. The fetus will generally have a unpleasant odor and will not exhibit any signs of life. They will also be very discolored, usually very ashen gray. And carefully wrap the newborn in a blanket and turn your attention to the mother at who is going to need more emotional support than anything. But don't forget to provide that physical care as well, as this is a very emotionally traumatic experience. In the event of multiple births, the mother or the pregnant woman typically knows this in advance, whether they are going to have twins or triplets or so on. But there are instances where it is not known and you can be surprised with a second delivery. So always be prepared to repeat the procedures that you just completed and be ready for round 2. In the event that there is excessive bleeding after delivery, always remember 1 to 2 cups of blood loss is pretty typical in a normal delivery. However, if the bleeding continues, you can encourage the newborn to nurse at the mother's breast. This helps stimulate the uterus to contract, which will help stop bleeding. Also, massaging the uterus externally can help stimulate the uterus to contract and stop bleeding as well. If the area between the mother's vagina and anus is torn and bleeding, treat that like you would any other open wound. You can use the clean sanitary pads as your primary dressing. If there is severe bleeding, place 1 or more of those sanitary pads over at the opening of the vagina. Elevate the patient's hips and legs and treat for shock. Keep her warm and arrange for rapid transport. Pregnant women who have been involved in any type of motor vehicle collision need to be examined by a physician. Forces involved in even a minor crash may be great enough to cause injury to the woman or the unborn child due to the excessive pressure and stretching and all the anatomical changes internally. Promptly assess your patient and arrange for transport to the hospital. If she exhibits signs and symptoms of shock, treat her accordingly. Monitor your airway, breathing, and circulation. Administer high-flow oxygen if it's available. And have the woman lie on her left side rather than on her back. And this will help alleviate the pressure off of the aorta. Rare circumstances, a crash can be severe enough to kill a pregnant woman, but not the fetus. So provide CPR to the woman while transporting her to the closest medical facility. This would be one instance where we don't stay on scene to perform CPR. We're going to try to do that while en route to the hospital. Okay, in summary of Chapter 16, some key indicators to estimate how soon delivery will occur are the presence of crowning or the absence of, the time between contractions. Remember, 3 minutes or less, we were kind of running short on time. 2 minutes or less is pretty much imminent. And then 5 minutes or greater, we have a little bit more time to work with and possibly enough time to transport. Remember, stage 1 of labor, initial contractions occur or begin, the bag of waters or bloody show occurs, or the bag of waters breaks. But remember, the newborn's head does not appear during contractions. In stage 2 of labor, this is when the newborn's head does appear during contractions, and this is the time when you would want to pull the ambulance over or prepare for delivery. Stage 3 of labor involves delivery of the placenta. You must assist in stabilizing the condition of the mother and the newborn and delivering the placenta. So keep in mind, this is probably a good time to call for some additional resources, some extra hands. And then, of course, exercise standard precautions when assisting with the delivery. If you don't have sterile PPE, standard PPE, gloves, eye protection, and face shield, and possibly a gown, those will suffice. After delivery, you will have 2 patients to care for, the mother and the newborn. If the newborn does not breathe on its own within the first minute after birth, proceed to neonatal or infant resuscitation. Although most pregnancies and births are uneventful, you should be aware of the possible complications, including ectopic pregnancies and shock, vaginal bleeding and miscarriage, premature births, unbroken bag of waters, a prolapsed umbilical cord, breech birth, limb presentation, stillborn delivery, or even multiple births, and excessive bleeding after delivery. So we have some review questions of Chapter 16. For the EMR, assisting with delivery involves, is it 1, determining exactly when the woman will deliver, or 2, transporting the pregnant woman only, 3, supporting the newborn's head as it emerges and telling the woman to stop pushing, or 4, pulling on the newborn to expedite birth? Of course, the answer on that one is going to be 3, better known as C, supporting the newborn's head as it emerges and telling the woman to stop pushing. Remember that once the head is completely out of the vagina or the birth canal, the rest of the body will follow shortly thereafter. Question 2, as soon as the baby is born, it is important to 1, cool the baby to stimulate breathing, 2, ensure that the baby is dried and warmed, 3, keep the newborn's head higher than its body, or 4, immediately cut the umbilical cord. The answer is going to be 2, better known as B, ensure that the baby is dried and warmed. On to question 3. Complications of pregnancy include all of the following except, is it 1, premature birth, 2, prolapsed cord, 3, breech birth, or 4, multiple births? And it's going to be 4, also known as D, multiple births. While some folks may consider this to be a problem, this is actually pretty normal, and the second birth should repeat the first birth. Okay, that's the end of this Chapter 16 covering childbirth. Remember to go back and pay attention to your learning objectives for the chapter, review your chapter in your book for studying material. And if you have any questions, feel free to email me or message me in the class chat. And we will be getting into Chapter 17 next. Thank you very much.